Hello, my name is Susan Hepburn, and I'm going to talk with you today about how to approach differential identification of students in the education system who may have either a serious emotional disability or an autism spectrum disorder, or sometimes both. Our objectives for this webinar are that after we've concluded, I am hoping that our audience members will be able to identify some challenges that are inherent to this process of conducting educational eligibility evaluations, particularly for students being considered under the category of serious emotional disability. I also hope that learners will be able to describe the elements of a comprehensive evaluation for SED in the schools, and distinguish 5 ways that students who meet criteria for SED likely differ from those who meet criteria for ASD. My 3 main points are going to be very familiar to those of you that are actively engaged in educational evaluations. First, that doing this work is complex and challenging, particularly in my experience when we're talking about these 2 eligibility categories. Secondly, that there are specific aspects of the evaluation process that hopefully will help to inform whether SED or ASD is the most appropriate category to demonstrate eligibility for special education. And oftentimes, one may be primary and the other secondary. And then third, that we can learn from research derived from educational and clinical sources, which will give us some clues about which behaviors are more likely to be seen with students in each of these categories. So in today's webinar, I hope to begin by going through a brief review of definitions of both eligibility categories. And then I'd like to spend a little bit more time going into detail about what we know about students with SED in the United States over the past 10 years. Then I'd like to talk about the challenges of identifying SED and the recommended assessment practices for determining this educational eligibility. And then lastly, we will discuss, I hope, some very specific examples taken from the literature on the behaviors and behavioral style to look for, which may help you to differentiate between students with social maladjustment, which we'll talk about in a few minutes, those with serious emotional disability, and those with an autism spectrum disorder. So let's start with the definitions of SED and ASD. Now, what I'm about to share with you comes from 2 guideline documents which are available to you through the CDE website. These definitions. The 4th potential characteristic is a general pervasive mood of unhappiness or depression. And the 5th, a tendency to develop physical symptoms or fears associated with personal or school problems. Now, the authors of these definitions are careful to acknowledge that emotional disturbance does include schizophrenia, and thus by extension probably would include psychotic disorders from the clinical world or reality testing problems, but the term does not apply to children who are, quote, socially maladjusted, unquote. And this will become a very important distinction as we proceed through this evaluation process. We will return to this sort of exclusion criteria within the rule a bit later in the talk. Now, as with any other educational eligibility category, it is very different than a clinical diagnosis out there in the medical or practice world. So as many of you know, a clinical diagnosis and an educational eligibility identification category are not interchangeable. So a student doesn't need to have a documented psychiatric diagnosis to meet criteria for SED. And in fact, having a psychiatric diagnosis isn't sufficient for meeting criteria for SED. What's really critical is that the student has behaviors that reflect the criteria and that those behaviors are having an impact on school functioning, such that they are getting in the way of the student's ability to participate and engage and access general education activities. Now, while we know that these 2 systems are independent of each other and are not interchangeable, It's also important to keep in mind that there is some research that suggests that there, in the real world, really is quite a lot of overlap. In fact, in one pretty well-designed epidemiological study from almost 20 years ago, they did find that 70% of 1,600 plus youth with SED also met criteria for a psychiatric diagnosis when they did in-depth mental health interviews. So the bottom line would be it's likely that students who meet criteria with SED would also meet clinical criteria for a diagnosis, but it's not necessary to receive special education under the category. So now with that very brief review, let's move to what we use as our definition of an autism spectrum disorder in a school setting. This also comes from the guidance that is posted on the CDE website, and I'll be very brief in my review here. So a child with an autism spectrum disorder is a child with a developmental disability, meaning that their symptoms change over time, and they are significantly affected in their verbal and nonverbal social communication, as well as their social interaction skills. And autism spectrum disorders are generally identified, or at least in evidence, by the age of 3. Now, there are several other characteristics that are associated with ASD, and the guidelines go into several different examples of each of these. For our purposes today, let's just keep in mind that those characteristics are engagement in repetitive activities and stereotyped movements, resistance to environmental changes or changes in daily routines, and unusual responses to sensory experiences. Now, the guidance also continues to say that an autism spectrum disorder in the schools needs to prevent the child from receiving reasonable educational benefit from general education, as evidenced by having at least one characteristic in each of 3 areas. And as you can see from this slide, each of these 3 areas basically corresponds to the first one is problems in social relating. So the student demonstrates difficulties or differences in interacting with or understanding people and social events. Secondly, these are problems in the area of communication, that the student displays significant difficulties or differences which extend beyond speech and language to other aspects of social communication, or what we might call pragmatics, both receptively and expressively. And then third, that the student is seeking consistency in their environment to the point that they exhibit significant rigidity in routines and may display marked distress over changes in that routine. Or in this third area, one may find students who aren't so impaired by routine changes, but could really struggle by having a significantly persistent preoccupation, either with a particular object or a particular topic. As with SED, a clinical diagnosis of autism is not interchangeable with an educational identification. So you don't need a clinical diagnosis to be eligible for an educational identification of ASD, and by the same token, having a clinical diagnosis isn't sufficient for being determined to be eligible for special education under the category. Sorry, there's an error on that slide. That should say meeting criteria for ASD. So just like with SED, we need to see impairment in functioning, an impact on school functioning for a student to receive an educational identification of autism. So let's go into a little bit more detail on what we know from the research about students with SED. Now, I'm focusing a bit more on SED in this talk because we've covered the topic of autism spectrum disorders in seminars like this in the past. So a few facts to keep in mind. Less than 1% of all students in the United States has an eligibility category of SED. About 7.5% of the students receiving special education services in the country are served under this eligibility category. And interestingly, even though these are relatively small numbers, these students are much more likely to be in restrictive settings than students in other eligibility categories. For example, 6.4% of students in special ed who are primarily in general education are in the SED category. In contrary, and then in addition, think about this one, that 32.5%, so almost a third of students in special education who are in segregated settings are receiving services under the category of SED. So here we have a relatively low number of students being identified, but those who are identified are apparently significantly affected enough that their restricted placements are much more common, and actually they are more likely to be in a restrictive placement than people in other categories. As various researchers have looked at the available education data, they've discovered that students with SED are much more likely to have problems with externalizing behaviors than with internalizing. In other words, students whose behaviors are disruptive, perhaps aggressive, or have tantrums, are more likely to be identified with SED, and we see an underrepresentation nationwide of students with internalizing problems like anxiety or depression. So that has given an awful lot of scientists, clinicians, and educators some concern, because it appears that far fewer students are being identified under this category than they should be, based on what we know about the epidemiology of mental health in youth. So let's take a look at that. These data come from a meta-analysis on several studies that were conducted from clinical sources of information. And these clinical sources were interrogated right around the same time that we were able to abstract those data I just shared with you, that less than 1% of students receives this particular educational classification. If you look at it, you'll notice that if we consider any serious emotional disturbance, which could be depression, anxiety, a disruptive behavior disorder, even ADHD was included in this particular study, preschoolers, about 12% of those would meet criteria using psychiatric semi-structured interviews. And you'll notice that the rates are pretty similar when we get to school-age kids. About 13% have a serious emotional disturbance. Once we get to adulthood, our risk for these things increases, as you'll notice across the different disorders in this chart. But interestingly, it is thought that most emotional disturbances begin in early childhood and persist across the lifespan. So as you'll see, we have approximately 2% of preschoolers meeting criteria for depression. In the school-age years, that goes up to about 4%. In adults, it's about 7%. And these are what's described as point prevalence estimates. So 1 point in time, how many people would meet this. Anxiety disorders, also very, very similar between preschool and school-age children, about 8 to 9%, whereas adults have more of like a 17% risk of having an anxiety disorder. Disruptive behavior disorders tend to stay pretty stable across the lifespan, even beginning in the preschool years. So when we look at those numbers, even if you just took one of those particular conditions, there are way more people affected by mental health conditions, way more children and youth than are currently being identified in the school system, and therefore receiving individualized services. So that brings us to a really important point, which is part of why we're even doing this webinar. Why is it important to identify SED? Well, particularly given problems in access to care for behavioral health or mental health, schools are thought to be the primary provider of mental health services for youth in the United States, at least according to the American Academy of Pediatrics. And since most psychiatric disorders are starting in childhood or adolescence and do persist, particularly if untreated, it becomes all the more important to find ways to identify who's at risk and try to prevent that condition from getting worse, or provide the interventions that perhaps could not only impact the person's well-being in the immediate future, but could have a lasting impact moving into adulthood. So it's important to figure out which youth are presenting with these mental health conditions that we refer to as a serious emotional disturbance. We also know, or I'm sorry, serious emotional disability. We also know it's incredibly challenging. Some of the challenges really start with what it is that we're looking at. As we know, emotional functioning in human beings is really complex. It's multifaceted, and it likely changes over time. A person could meet criteria for a condition at one point in time, and grow out of it, and perhaps present with a different condition later. Similarly, as each of these presentations changes, sometimes you'll have situations where at young ages the condition looks a certain way, and then as individuals get older, the condition looks different based upon the developmental changes. For example, let's consider depression. It's thought that under the age of 8, depressive symptoms are equally common in boys and girls. It isn't until after puberty where girls begin to show an accelerated risk for depression. So risk is somewhat similar before puberty, and after puberty, females are at increased risk. That would be an example of developmental complexity as we're trying to understand a person's emotional functioning. It's also important to remember that emotional functioning occurs on a continuum. There's no clear red line between what's a normal emotional response and what's an atypical one. It's also something that is going to be culturally influenced, not only in our broader cultures, but in our family culture, all sorts of levels. For those of you that might remember the Bonfenbrenner circles that overlap on top of each other, there's your family that's around the child, then the neighborhood, the community, etc., etc. Each of those layers of culture likely impacts an individual's emotional functioning. Emotions are also biologically influenced, and there could be all kinds of pathways towards developing an emotional disturbance. And some of those pathways are very complex and hard to understand, and could be a combination of biological and environmental factors. Our emotional well-being, our emotional skills are all very socially influenced, and the mental health of our parents and family members can have an impact on our own mental health. So many times when we discuss the emotional functioning of a child with parents, we are really traveling on some very personal ground. And it's quite possible, knowing how genetic many of these conditions are, that educators could find themselves talking to a parent who's had a history of struggling with some of the very behaviors and symptoms that you are trying to understand that are being presented in the student. So conversations around the educational identification of SED can be very sensitive, very personal, and in that way, I think, quite challenging for everybody at the table, both for the school psychologist, speech path, OT, everybody, as well as for the family and for the student, particularly when they're involved in these meetings after the age of 15 or so. Now, we could do an entire webinar on issues of culture and SED. We don't have the time for that, but what I do want to point out are a couple of really important facts. So the first is that there's a great deal of research that suggests that the culture of the student and the cultural match between the student and the educators really matters in this educational identification process. In fact, there's significant evidence for disproportionality. In other words, we see in the data more SED in certain subgroups than would be expected. So the thought is, and several different researchers have looked at this in different educational data sets with different analytic methods, and they have discovered that males are disproportionately represented in this category. So of the students who receive the classification of SED, 8-to-1 male to female ratio. There's also a much larger proportion of African Americans in the data, which is leading to an awful lot of concerns about how assessments occur and whether or not there are some cultural mismatches between the people evaluating and the people who are being evaluated. Children that come from single-parent households are overrepresented in this category, as are individuals who have come from low SES areas or impoverished areas or have few socioeconomic opportunities. If more than one of these things happens, a male who's African American from a single parent household in a low income neighborhood, the risk of being categorized in SED over any other special ed category goes up exponentially. So several researchers have been examining this phenomena and are making recommendations about how to improve our process so that we are being fair and appropriate in our allocation of this particular categorical label. So in the area of culture, the other problems that we have in the field is that very few of our assessment tools are normed on diverse samples or available in multiple languages. So many times, school psychologists and other educators are put in the position of using the tools and checklists that you have available, but they weren't normed on a group of students that is at all similar to the student that you are evaluating. And this is a real limitation and quite difficult to grapple with. It's a problem that no one school psychologist can solve except to try to find the best measure available and to include in the report any disclaimers if the norm sample of the tool does not represent the students being evaluated. And then lastly, the cultural match between the evaluator and the student is very important, and building rapport between evaluator and student is very important. So culture can really impact educational evaluation processes and seems to particularly impact classifications in the SED category. And a lot of people who are studying this suggest that that's because the criteria appear to be very vague, as we said. Now, when you are dealing with criteria that can feel somewhat subjective, it's important to note that in a way it kind of had to be written that way because they're trying to have a broad net to be able to identify a variety of students who may have different kinds of emotional difficulties. Trying to put kids with externalizing behavior problems in the same sort of category as children with internalizing behavior problems is right away problematic because they are likely to express those behaviors in very, very different ways. So we know going into it, we are working with criteria that are somewhat vague, hard to operationalize, heterogeneous population. Because of that, as evaluators, we need to keep in mind that there's a greater risk that we could unintentionally make a cognitive error in our assessment process. Our tendency to make these sorts of judgment errors increases when we are working with heterogeneous populations and vague criteria. So two of the cognitive errors that I would like to mention are things that the research suggests we pay attention to. They are also things that I've run into in my own work in the schools on educational identification and something that I've struggled with trying to question myself about. And I think that's really the best we can do, to just ask yourself the question, have I possibly had an error in judgment here? And do that kind of self-monitoring throughout the process. So briefly, those two errors which are thought to be the most common in this particular differential. The first is a confirmation bias. And this is where we have a tendency to seek out evidence that will confirm what we initially believed was true. So this has to do with, if you think a child has depression, only choosing measures of depression. In order to counter that bias, you would also want to include measures that don't tap depression but could reflect other aspects of the student's presentation that might be important, perhaps an executive function or an attention measure, perhaps a social skills measure. So confirmation bias is when you are making decisions about what information to include based on what you believe to be true, and you want to try to broaden your choice of measures. Second is this, what social psychologists call a belief perseverance, or perseverance, I suppose. This is a tendency to maintain your own belief even in the presence of evidence to the contrary. And this is something that all of us are vulnerable to, especially if it turns out you've had a lot of experience as a practitioner. Evidently, new practitioners are less vulnerable to the belief perseverance error. It's the experienced clinicians who, over time, might become more confident, which is good, but can also jump to a conclusion and kind of develop a blind spot about evidence that runs contrary to their belief. To me, one of the best ways to combat this one is the team process that we are engaged in when we're doing an educational evaluation. If there's several people coming together to think through the data, then one person's tendency towards a cognitive error is much less likely to be problematic. So just something to be aware of. This is difficult to do, and we can only do our best by just trying to self-monitor as best as we can. Now, another challenge of identifying SED is that it's important to recognize that rarely does a student come to us with just one condition, just one problem area. In fact, comorbidity or co-occurrence of disorders is more the rule than the exception. And interestingly, when disorders co-occur, the impact is usually more severe. So, given that less than 1% of students receive this eligibility, it's thought that students who get referred for an evaluation for SED are probably not mildly affected. That in a way, you're more likely to hear referrals from teachers from students who have multiple conditions and likely more significant impact. So comorbidity is probably going to be present. Let's step back for a second. I wanted to just share a little bit of evidence about the co-occurrence by telling you a little bit about a pretty neat study that was done in Kansas a couple of years ago. This is Bryson et al., 2011, I believe, and it's in the reference list. So this particular research group looked at the records of 26 community mental health agencies in the state of Kansas. They went to 26 counties. They reviewed the records of all children and youth, ages 3 to 18. They found that of the children with autism in those records, more than 75% of them would have also met educational criteria for SED. And when they looked at those comorbidities, they determined, this was back in the days of DSM-4 for clinicians, where you had autism as a kind of classic autism phenotype or presentation, and then you had the broader spectrum, things like Asperger's syndrome or PDD and OS. So what the Kansas group found is that if the student had more classic autism, the co-occurring mental health conditions most likely to be noted in their record were obsessive compulsive disorder and disruptive behavior disorder. If the student presented with a broader spectrum, more likely to have ADHD, anxiety, depression, bipolar, even oppositional defiant disorder. And the risk of psychiatric hospitalization was much greater for the broader spectrum group, which also was higher functioning intellectually than the classic autism group. So this Bryson et al. Study suggests that actually less than 3% of children with autism are actually seen in community mental health centers. But when you look at that 3%, 75% of those would have also met criteria for SED. Thus, this is likely a very, very high rate of comorbidity. So let's step away then from those facts and take a look at what the recommended practices are for identifying serious emotional disability. Well, in order to differentiate it from ASD, so how do you get to this information? Well, a couple of writers have described the best practices for assessing SED in the schools, and in general, they come up with an overall set of guidelines that's actually quite similar to what the field of autism assessment would recommend, with a few changes. So basically in SED, clinicians are recommending a multi-method, so in other words, observation, interview, perhaps some norm checklists, some standardized testing, along with multi-informant. You want to hear from the teachers, perhaps even teachers who see the student in different kinds of contexts, large group versus smaller, unstructured versus structured. It's important to hear from parents. And in fact, homeschool collaboration is absolutely essential in these processes, and understanding how the students present at home currently as well as in the past will be very useful. Now, lastly on multi-informant, student input is also really helpful. So spending time talking with the student, or perhaps doing some social emotional understanding tasks, or doing some storytelling, doing some projective drawing, or even just doing some unstructured play, getting to know the student, collecting a language sample, and if they're old enough and capable of talking to you about it, once you've built rapport, finding out what their experiences are with this condition, especially if it's an internalizing condition, where maybe what they're feeling inside isn't readily apparent to the people around them. And then lastly, in this multi-method, multi-informant kind of approach, it's really important to do an in-depth record review, and in my mind, requesting from the family any clinical or medical reports that they'd be willing to share that they think would inform the educational evaluation process is a really important thing. Now, we know that having a clinical diagnosis doesn't mean it automatically translates to an educational identification, but it is important, I think, to consider that information, to include it in the record as the team tries to make this determination. So in addition to multi-method, multi-informant, we also want to be multi-setting so that you understand what things are like in the home, in the community, at school. If the student lives in more than one home, maybe there's shared custody, understanding what it's like in both homes is recommended. In addition to collaborating with the family throughout this process, it's also important to make sure that the assessment covers the student's strengths and interests. So regardless of the outcome, if we can learn things in this process that will have a real impact on programming, we will have a better chance of supporting this student. So even finding out what kinds of motivators could be used if a behavior plan is needed, or what focuses or interests are really compelling so that perhaps they could be added to curricular elements, those things could be very useful in programming. And talking to parents and students and teachers about a student's strengths are also thought to be an important part of shaping the way people think about a student. So if we approach this from a motivational interviewing kind of approach, the active assessment can be, in a sense, an intervention, particularly if people are focused on understanding the whole child, including the strengths and interests. Now, as you're gathering all of these data, it will take a bit of time, so keeping the family informed as to where the process is will be important, and adopting a clear, objective, scientific approach to analyzing the data that you collect will be important. And basically the role of the school psychologist and other team members will be to present the data, and then as a team, including the parents, as you know, come up with the appropriate educational category. So the job of the clinicians on the team is to gather the data, analyze it and summarize it, and then the team together makes their determination. And this is actually very, very similar to what we do in best practice in assessing for autism spectrum disorders in schools. The one thing that I would add is that you want to be sure to use a measure, oftentimes a student interview, which directly assesses social reciprocity, behavioral flexibility, and nonverbal and verbal communication. So several of you might be familiar with the ADOS, the Autism Diagnostic Observation Schedule. It's designed specifically to give you direct observation of the student in certain situations that tap those three capacities. More and more, as we learn about autism, we are learning that the executive functioning of the student, even though that's not necessarily a core criteria of the identification itself, that executive function set of skills has a lot to do with how well they can do in school. So understanding where a student is with regard to planning, organization, initiation, all of those work behaviors, as well as their ability to coordinate and regulate their attention and emotion, can be quite helpful as you move into programming. So now let's turn our attention to what we've learned from the research about how to tell some of these things apart. And please know that I'm just going to give you a couple of examples on different categories. And these are somewhat general in the sense that I don't want to be prescriptive. So you could have an individual student who presents in a way that isn't consistent with the slides I'm about to show you. That doesn't mean that they don't actually have the condition. I'm trying to offer these up to you as examples, and they hopefully will just prompt some thinking as you work with different students. But as any time you work with complex young people, there are going to be exceptions all along the way. So as you're gathering these data across these different instruments, and you step back and you look at it, one of the things that I thought would be helpful would be if we were to add to a document which is included in the guidance at CDE that was adapted from a couple of different school districts. Their purpose was to compare and contrast social maladjustment from serious emotional disability. And I've gone ahead and tried to brainstorm what the autism version would be of each of those. So let's take this opportunity to talk briefly about what we mean by social maladjustment. When IDEA was revised in 2004, the committee wanted to make sure that they were not suggesting that students who presented as socially maladjusted, meaning they tended to be defiant, maybe be in trouble a lot for breaking rules or in trouble with the law, perhaps had joined a gang, that those students, to the authors of the 2004 guidelines, those students were not to be included in the category of serious emotional disability. And the authors of these guidelines felt that those students would require not necessarily access to special education, but a different set of supports. Now, this is very controversial, and some states have decided to include students who would meet criteria for social maladjustment under serious emotional disability. Others have said, let's not exclude them for social maladjustment, but let's examine their, are they vulnerable to an intellectual disability? Do they have a learning disability? Are there speech language problems? So those students who tend to get in trouble a lot with authority figures are now being recommended for a full assessment and could be in some states eligible for serious emotional disability if they meet criteria for another learning problem. That's a bit simpler. In the state of Colorado, we still have the exclusion for social maladjustment, so that special education services are not offered to students who are ongoing disciplinary problems. So that's the lens I'd like you to have as we look at these comparisons. And I hope they're useful. I'll be curious to hear your feedback. So in the area of peer relationships, a student who is described as socially maladjusted often has a lot of friends, may even be a member of a subculture of like-minded peers, whereas a student with a serious emotional disability, their peer relationships tend to be short-lived, they tend to cause a lot of anxiety, and there's often a lot of chaos or drama, so there's kind of a in-out sort of flavor many times to their peer relationships. Now in the case of autism, the peer relationships are often facilitated by an adult or require a little help to get started. Oftentimes, especially in the elementary years, there's a one-sided quality to the friendship. As the student with autism gets older and learns social skills, that can make some qualitative shifts. In general, students with autism can have a very strong sense of loyalty about a friend, But they may also make judgments where they see the friendship as in a different kind of level of intensity than maybe the peer sees it. They can tend to get overly focused on a particular peer and may have trouble following kind of the boundary rules of how to interact with a friend. So as you can see just from this chart, what we're trying to get at is that many times autism is different from a serious emotional disability in the sense that there's a lack of social skills in autism, whereas in serious emotional disability, it's thought that the affective disturbance makes it hard to interact well, but problems in core social relatedness haven't been a part of this child forever, but they are impacted by their mental health. When we look at the domain of understanding other people, we can really think about two different ways of approaching this. There's understanding other people in a cognitive way, which might include things like taking another person's perspective or being able to identify a person's motive or intention. Then we can also look at it in an emotional way, which has more to do with a capacity for empathy and understanding another person's feelings. So as you can see from this chart, youth who are socially maladjusted are thought to have intact cognitive intersubjectivity, we call it. So their understanding of other people is often quite good. They're thought to be pretty skilled at reading other people's intentions and may actually act on that in a manipulative way. Whereas students with serious emotional disability also usually have pretty good intact cognitive perspective taking. However, their interpretations of other people's thoughts could be skewed based on their emotional state. So if a student is currently going through an episode of depression, they are more likely to make some negative attributions about the other person's perspective. But when the depression has lifted a little, that skewedness towards the negative should kind of return to baseline. So in general, the cognitive understanding of other people is thought to really be impacted by either the emotional distress or the attentional focus of the student with SED. Now, this is very different than autism, where the cognitive understanding of other people is often developmentally delayed by a couple of years, and they may present as somewhat naive about other people's intentions, perspectives, and thoughts. And many times they misinterpret what they think someone else is thinking. Now, children who are intellectually more competent can tend to learn these things more quickly, but the ability to take another person's perspective and understand their intentions could be a way of teasing out SED from ASD. The emotional realm of understanding other people is also highly relevant. Youth described as socially maladjusted are often described as callous and unemotional. That's a phrase you may see in the literature more and more, because they're discovering that there's a developmental continuum between callous and unemotional preschoolers and teenagers who present with conduct problems and end up involved with the law. And it's thought that this may be getting to that group of vulnerable youth. So they tend to present as unsympathetic to other people's heartbreak or loss. They tend to not show remorse when they have done something that may have hurt somebody else, and they really don't seem moved or affected by another person's pain at the level that you would expect. In SED, that emotional understanding of other people can be really intense and overwhelming, so that there's almost like a lack of a filter. It's hard to keep somebody else's emotions out of their sort of emotional experience. Or on the other hand, their emotional understanding of others can be kind of blunted, where they don't take in the information, and it's thought that it's almost done in like a self-protective kind of way. So if an 11-year-old is going through an episode of depression, it's just too painful to go to a movie where something sad happens to an animal, and that particular student might just reject any sort of engagement in any kind of difficult emotional terrain that reflects somebody else's pain. So in SED, it could be too intense or it could be kind of restricted. But in general, it's thought that when their emotional illness isn't present, that they understand other people's emotions pretty well. And this is quite different in ASD, where depending on the age and the person's functioning, in general, they're somewhat unaware of other people's emotions, or it might even be and they might get disorganized by other people's emotions. And that could be happiness, it could be sadness, and they may misread what happened just before a problem occurred, and they may not really understand what made someone mad, what made them sad, and need some help making those connections. Now, the area of nonverbal communication is one that I've become very dependent on when I'm trying to make a differential identification. To me, problems coordinating verbal and nonverbal behaviors is such an important hallmark of autism that it's a really critical area to examine, and this works across the lifespan. So when I'm trying to understand if a child's presenting with autism or something else, and I see really good eye contact, I see coordination of gestures, I hear voice tone that varies with emotional cues, I might be moving away from thinking it's likely to be autism, because those problems appear to be a biological part of the syndrome that lasts across the lifespan. So in the area of think of eye contact, facial expression, changes in voice tone, and think about how we're supposed to naturally be able to kind of coordinate those with our verbal communications, and that we modulate those to the right intensity. So a person with autism could have poor eye contact because they don't look at the speaker, or, as we often see in girls, they are looking at the speaker too long and too hard. So it's the modulation, not if it occurs or doesn't. So let's start with ASD this time. In ASD, students across the lifespan tend to use nonverbal behaviors less often. You're likely to see fewer gestures. You're likely to see fewer changes in affect in their face, or perhaps even hear it in their voice less often. These nonverbal behaviors tend to be less well coordinated with each other. They might talk to you while not looking at you, for example. And then when they do use their nonverbal communication behaviors, there's a qualitative difference in the way they're executed. So you might find that gestures look over-practiced, or the timing is a little off, or the duration, as we mentioned, of eye contact is a little off. I put a lot of weight too on prosody, or the rate and rhythm of a person's speech, and if they're changing speech tones in order to convey emotional information well, that is not very consistent with autism. Some high functioning people can do it, but a voice tone that sounds very robotic or sort of staccato or devoid of emotion, or putting the wrong emphasis emotionally in the wrong place could be a sign of autism. Now, SED is going to differ. They tend to use nonverbal behaviors just as often with their verbals, unless the child is going through some kind of trauma or depression, where you could have some withdrawal, and that would include, limited nonverbal exchanges. But in general, the modulation of these nonverbal behaviors with their verbal ones are probably varying with their affect. They're not consistently impaired, but they reflect the emotional state of the student. Now, it's thought that this differs from students who are socially maladjusted, where nonverbal behaviors are thought to be used pretty often with their verbals, and that the modulation is thought to occur in a fluid way. So there isn't quite as much difficulty as could be evident in a student who's going through depression. Now, in the area of affect, a person who's socially maladjusted is usually able to naturally match their emotional displays with the situation. So what their face looks like makes sense for the situation they're in. And this often is presented within normal mood variations, good moments, bad moments, just sort of the variety you'd see in any particular young person. Children who are described as socially maladjusted are thought to lack the appropriate guilt or even shame for their actions. And they may have enough social cognition or understanding of other people to actually fake an emotional response in order to achieve a goal. So by being able to pretend to have a feeling, they have to be able to read the situation and recognize that if I present like this is my feeling, then that person will do this and I'll get what I want. That's thought to be more of the antisocial or this social maladjustment than what we see in autism, which is often described as asocial. So when we look at autism in the area of affect, what we see is that many times maybe they're laughing and there's no clear cue, or they've become sad and you're not sure why. So their affective displays may not match the situation. They may seem out of context, at least some of the time, or kind of in their own head, in their own narrative, and what they're showing on the outside doesn't seem to give you clues to what they're actually feeling on the inside. There's a tendency for the moods of a person with autism to have an on-off quality. There's a good moment and a bad moment, and there's almost like a switch for some of these students. They may have a limited range of expressions and either present as sort of flat and serious, or maybe happy all the time, or maybe they look worried all the time, even when they aren't. This doesn't affect everyone, but there's a tendency towards a limited range of expressions. When they do have those emotional expressions, they tend to not direct them to other people as a form of communication. Rather, they're more self-directed. And then lastly, in ASD, we see in the literature and through clinical experience that there's a tendency to deny experiencing any negative affect. So if you've ever worked with a student where you say something like, you look sad, and that student just says, I'm not sad, I'm not mad, it's almost as if the word and the state are equal or something in the person's mind, but you'll get students who absolutely deny having a negative affect, even though it's quite clear that they probably are feeling disappointed or sad. So students with SED are different than both. It's possible that their affect doesn't match the situation. Sometimes it will. Their moods are likely to swing and go back and forth, good days and bad days. And at times they could present as really overwhelmed by their own feelings or by the feelings of people around them. And just as we've talked about for other dimensions, the affective state of this student seems to really impact their openness to learning. That when they're having a difficult day, it might be harder to persist through a difficult worksheet, whereas on another day, they could persist just fine. So the affective state of the student with SED might impact how well they present, whereas in ASD, these things are internal and not as likely to change with mood states. Just a couple of more that I want to share with you here, and then we'll finish up for today. In the area of conflicts and tension, one of the things you'll see in the literature is that children described as socially maladjusted are thought to be pretty provocative, oppositional, hostile, and may have a history of breaking rules or laws. The thought is that conflict is a part of their experience, and some authors suggest that these youth are actually seeking it, that they get some kind of a reinforcing quality from high tension or conflict. Other writers will say, well, that's a very judgmental statement, that those students who present that way, they're coming at this set of behaviors because they themselves are in pain, or they have been hurt in the past, or they don't know how to manage a lot of things that are happening around them. And so that's part of this debate between how do we know what underlies those behaviors, and by pulling out these students and calling them socially maladjusted, are we blaming them for the very problems that we ought to help them with? So that is part of the debate. In differentiating social maladjustment from SED, there's a lot of research that suggests that most youth with a serious emotional disability are not provocative as much as they are reactive. So that when something happens and they respond, like a fight or flight sort of response, or in a habitual way to some sort of stimuli, that there's a pretty high risk of being avoidant and of trying to just not have to deal with the things that are overwhelming. So you're more likely to see high rates of school refusal in this particular subgroup, or avoiding confronting problems or avoiding asserting themselves. There's often a low tolerance for distress, where maybe that's where part of the avoidance comes from. This person with this profile may just really want to seek safety, and that any kind of emotion dysregulation is scary and uncomfortable, and so they may do whatever they can to just end that discomfort, which often means withdrawing or pulling away from the potential conflict. It's also suggested in the literature that students who receive SED have ongoing chronic experiences with conflict, that they frequently have ongoing problems with peers, siblings, parents, and teachers. They can sometimes be perceived as provocative, but more often they are avoidant, and they tend to have more somaticizing symptoms, so they have physical symptoms that seem to reflect that they don't feel good about the situation. In ASD, they tend to get into conflicts with others or create tension because they can be so focused on themselves that they might get overly focused on a particular interest or topic and have a hard time letting go of that in order to go along with a rule change or something else. They may unintentionally really cause some difficulty. And they can also demonstrate what we refer to as an exaggerated sense of justice. So if they see a rule being broken, they may call it out. If they are concerned about fairness and something's been done differently with one person than another, that can lead to conflicts and can be really hard to help them understand that sometimes different people have different experiences, and fairness and justice aren't necessarily the same. And it's thought that the conflicts that happen for students with ASD is often happening because they have some true skill deficits, particularly in the area of understanding other people's perspectives and being able to be flexible and being able to regulate their emotions. Self-concept is also an important area to look at. Where in the area of autonomy, youth who are socially maladjusted tend to be pretty independent and self-sufficient, and in studies, they make decisions really quickly. Whereas students with SED tend to be overly dependent on adults, or on the other end of the spectrum, could be impulsively defiant, but in either case are often not able to have a lot of assertiveness or proactive kinds of autonomy or choice making. In fact, many students with internalizing disorders like anxiety or depression could have trouble making decisions. They may doubt their choices, or they might make those decisions impulsively and then get really stuck in regret. So there's a difficulty sometimes around moving on from one decision or behavior, whereas the self-reflection of the socially maladjusted youth may not be as apparent. In ASD, the thought is that many individuals with this condition really do prefer to do things on their own terms, but they tend to rely on the adults in the room to kind of keep the engine going, to keep things running. But they do like to have some sense of control of their own experience. They may insist on a specific routine or familiar choices, even if it doesn't quite fit the situation, and may need some help in knowing when what they want to do fits and when it doesn't. In the area of responsibility, youth who are socially maladjusted often blame others for their own problems, but otherwise they make pretty good attributions for what's going on with things, so they are in general reality oriented. In fact, they can show some pretty remarkable courage or sense of responsibility to their peers, but it isn't always towards a desirable end. It could more be that a couple of kids have gotten together and gotten in trouble and they protect each other out of loyalty. In SED, there's often a sense of role confusion. They don't really seem aware of what their responsibilities are, whether it's as a friend or as a son or daughter or as a student. They may be somewhat passive or confused about what they should bring to a situation. And they may have distorted interpretations of what others are supposed to do. One of the things that some students with internalizing conditions are vulnerable to is a sense of learned helplessness, where they feel really, really stuck, they don't feel very competent, and they just overly rely on other people to guide them because they just don't think they can do it. And so interventions that help them see their responsibilities and help them see that they can meet the expectations of others are often thought to be psychologically really important. In ASD, we have oftentimes an immature sense of responsibility, and that includes what they're responsible for in relationships with people, in certain situations, or even as a learner. That part of your responsibility is to hand in your paper, for example. And they don't tend to naturally reflect on their own behavior and often need to be explicitly taught what their responsibility or role is. And once it is taught in a skill-based, non-judgmental way, it can become a part of their routine. But they often have to learn that sense of responsibility situation by situation. One of the problems that parents of high schoolers are reporting is that they are very concerned that high school seniors or individuals in transition programs aren't quite ready to take responsibility for the decisions to emancipate and move towards adulthood. And parents are working really hard with their school teams and community providers to help them see their sense of responsibility for themselves as they get older. And then lastly, in the area of school functioning, what you may see is that youth who are socially maladjusted might resist school routines, and they may be at risk for truancy. The data are pretty significant for high risk of truancy in this subgroup of youth. Their academic school skills are often uneven, and their engagement is strongly associated with their interest in the material. So you may have some students who in some classes are performing just fine, but in other classes don't show up or aren't putting the work in. In SED, school routines are thought to be helpful. However, they are also often at risk for truancy, but it's less about resisting education and more about somatic symptoms, possibly anxiety driven, possibly depression, where it's just really hard to anticipate going to school and then to actually get there. Like their peers on this slide, their academic skills can often be uneven, particularly during times of emotional distress, whereas at times when those emotional difficulties aren't as present, they may have done better across academic areas. And their engagement in school is often associated directly with their mood, their overall wellness, their health, their sleep, their eating, all of those things. For students with ASD, school routines are usually pretty helpful, and data from research in the field suggests that there's a pretty low risk for truancy unless they have a co-occurring anxiety condition. And almost 70 to 80% of middle and high schoolers with autism experience some anxiety symptoms that are clinically significant. So when truancy is occurring for a student with autism, one of the things we wonder about is there some anxiety about coming to school? Academic skills also likely to be uneven, and as with their peers, their engagement in academic content is going to be strongly associated with their interest in the material. In fact, one of the interventions that can help get engagement is to take their special interest and bring it to the curricular material. So that's an awful lot of content that I've tried to toss at you there. My hope here is to just try to describe how evaluating students for a possible serious emotional disability or an autism spectrum disorder is very complex. It requires multi-method, multi-informant procedures, and it's essential to partner with families throughout the process. Your first task is probably determining what the behaviors of the student are like, and then your second task is to figure out what's interfering the most with access to general education. And this often requires a lot of team discussion, more than one meeting, in really trying to get to the heart of if these are the problems that are impacting school performance. Do they land more in the emotional realm, or do they land more in the ASD developmental realm? And as I mentioned very briefly at the start, it's possible that the team can say, we really think it's both, And at that point, you need to try to decide as a team which one is primary, which one seems to be driving what the students' barriers to accessing education are at the present point in time. Next, we want to remember that conditions are really likely to co-occur. This is not going to be a clean and simple differentiation. And one team could decide on an eligibility that works for 3 years, and at the next eligibility eval, it could shift to a different one. And that is exactly how the educational system was developed. It's not to come up with a diagnosis which is thought to last a lifetime. It's coming up with an acute summary of what's happening now, what's getting in the way now, and what do we need to think about as most primary in the needs for supports and services. And then lastly, my last point for today is to just try to encourage you to, as you are doing the measures to differentiate what category might work best and figure out if there is an impact on access to education, it's also really important to be doing functional assessments that will be able to give you ideas about programming so that you can really help the student to succeed in school, regardless of the category that the team decides upon. Having the evaluation data be able to be translated into real world programming steps is going to be a really important part of this process. So I've posted all of the references that inform this presentation. It's a really interesting literature out there, and I imagine that we will see more and more work being done over the next several years in perhaps refining the definition or coming to some consensus about how to do the differentiation. I've tried to give you examples that are based in the literature, and I've tried to connect those observations to clinical practice, but please know these are suggestions, and your own experience as educators is going to be really critical as you gather this information and work collaboratively with families and students to come up with an appropriate conceptualization. So thanks very much for your time, and if you have any questions or would like to track down a resource, feel free to contact me by the email provided here. Thank you very much.